we're going to talk about some basic concepts of refractive error. There are basically four types: myopia, that is short-sightedness; hyperopia, that is long-sightedness; astigmatism; and presbyopia. Now, just like to clarify some terms, in our culture, we tend to talk about how many degrees of refractive error. For example, 200 degrees of short-sightedness. Officially, though, we count the refractive error in terms of diopter, and one diopter equals to 100 degrees. When you are seeing a distant object and when light focus on your retina and give you a clear image, then you have what we call emmetropia. Minus sign is myopia and plus sign is hyperopia. And if you go to an optic shop for glasses, they will check your refractive error, and this is how they present your result. The first column is a sphere, so myopia or hyperopia. Second column is magnitude of the astigmatism, and the third column is the axis of the astigmatism. Now, as you can see, the right eye had a short-sightedness of minus 2.0 diopter, astigmatism of minus 0.75 diopters along the 90-degree axis. So we will talk about the axis later on. Now for the left eye has long-sightedness of plus 1 and also astigmatism of minus 1 along the 180-degree axis. The problem comes about when the image is not focused on the retina. When the distant object focuses in front of the retina, it is myopia. There are two types: refractive or index myopia and axial myopia. Now, index myopia means that the refractive power of the eye is increased. Causes include cornea steepening, increasing refractive power of the lens, say for example cataract, anterior lens dislocation or subluxation. Now for axial myopia, it means that the eyeball is too long. Pathological myopia is common, and that leads to all sorts of complications of high myopia that you could have imagined. For example, retinal detachment, myopic maculopathy, etc. This is a common problem in Hong Kong. Other causes include congenital glaucoma. The eye expands at the early stage of life because of high intraocular pressure, and so that lengthens the axial length, and placement of the scleral buckle of the retinal detachment surgery. Basically, that squeeze the eyeball at the equatorial region and lengthen the eyeball. Hyperopia is basically the other way around. So when distant object focuses behind the retina, it is hyperopia. Again, there are two types: index and axial hyperopia. Index hyperopia means that there is not enough refractive power of the eye to focus the image on the retina. This could be due to cornea flattening, decreased refractive power of the lens, say for example, again as a result of cataract, posterior dislocation or subluxation of the lens. Axial hyperopia means that the eyeball is too short. Indeed, hyperopic patients tend to have an eyeball with shorter axial length. So classically, we tend to believe that patients with hyperopia have a higher risk of developing angle closure glaucoma because the anterior chamber is also narrow in that case. Of course, the reality is more complicated than that, but let's leave that behind at the moment. Also happens in case of microphthalmos, retrobulbar tumor, choroidal tumor, and also central serous choroidal retinopathy, a condition where some fluid accumulates at the macular region underneath the retina and actually pushes the fovea anteriorly. Effectively, the light focus at the back of the fovea. Patient may also experience scotoma, micropsia, that means the objects become smaller, and also metamorphopsia, the image become distorted. Astigmatism is more difficult to explain. Imagine the light lands on the whole 360 degree of the cornea surface. Basically, in astigmatism, there's an unequal refractive power in different meridians, or just imagine the eyeball is now a rugby ball instead of a basketball. So when the light lands on this surface, the steeper meridian will focus the light in front of the retina, and the less steep part will focus at the more posterior position. When that happened, the parallel rays do not converge on a single focal point on the retina. Just like what you see in this diagram, the horizontal and vertical light rays have different focal points, and you end up having a blurred zone in between these two focal points. Astigmatism could be originate from the cornea in case of irregular cornea, such as dry eye, pterygium, and keratoconus. or as a result of the lens problem, so in cataract and also in lens subluxation. So astigmatism affects both near and distant vision. Finally, let's talk about presbyopia. This is a physiological insufficiency of accommodation, often occurs around 40 years of age, because the patient loses the ability to see things clearly up close. The reason is because of aging, and it's mainly due to sclerosis of the fibers of the crystalline lens, change in the lens capsule that reduce the spontaneous deepening of the lens surface and ciliary muscle contracts, and the ciliary muscle becomes less efficient with advancing age. There are some myths about presbyopia that I would like to talk about. The first one is, I won't get presbyopia because I have 20/20 vision. Of course, this is incorrect. Presbyopia is part of aging, it's not a disease, and we don't have evidence that anything could prevent it. The second myth is, short-sightedness prevents presbyopia. Well, not exactly. As I said, presbyopia happens to everyone, whether or not you have myopia or hyperopia. More correctly, presbyopia is that you lose ability to accommodate. Basically, for near visions, your eyes need to, if you like, do a bit of work in order to get the image focused onto the retina. Without the glasses, for people with emmetropia, the eyes are in the most relaxed status for distant vision, and they need to accommodate for near objects. As they get older, this action becomes more difficult. For people with hyperopia, the eyes need to accommodate even for distant vision, and they need to accommodate further for near objects. That's why they feel the presbyopic symptoms early, say before 40 years of age. Now for myopia, the eyes are in a relaxed status when focusing on near object. For instance, a person with a -1.5 diopters will have to spend the least effort when focusing on an object at approximately an arm length distance. Therefore, when they need to read, for instance, the eyes don't have to work as hard, so they don't feel the presbyopia at the early stage. That's why the presbyopic symptoms is sort of delay. They might even feel an improvement of the vision because they can now read without glasses, and they may even feel worse if they read with glasses because the glasses they have usually are designed for distant vision. The third myth is far-sightedness is the same as presbyopia. Of course, this is not true. Although both presbyopia and hyperopia result in difficulty seeing up close, hyperopia describes the condition when the image focuses behind the retina. So a young person with mild hyperopia can actually make up for it by accommodating further. Presbyopia describes a normal aging condition of losing the accommodation ability for seeing up close. There might be some similarities in terms of the symptoms, but the concepts are totally different. I hope this could help you to understand some of the core concepts about refractive error. Thank you.